Let's immediately jump into the first branching decision for joint pain on your Step 2 CK exam. We're skipping the fluff today and diving straight into the clinical algorithm. You've got to know how to instantly categorize a patient's pain, right? Is it traumatic or non-traumatic? Monoarticular or polyarticular? Acute or chronic? And honestly, the biggest thing for this explainer, can they actually bear weight on the joint?
Here's our diagnostic map for test day. We're going to run through branching logic and fluid analysis, compare osteoarthritis and rheumatoid arthritis, tackle the acute hot joint, look at pediatric joint pathology, and wrap it all up with a rapid algorithm summary. All right, part 1, branching logic and fluid. We're starting by sorting that non-traumatic swollen joint based on onset, timing, and, like I just mentioned, weight-bearing status. So here's the absolute game changer. If your patient literally cannot bear weight, you must, and I mean must, anchor on an infectious etiology instead of an inflammatory one. The infectious joint, it's acute, the pain is constant, and they absolutely refuse to put weight on it. Compare that to inflammatory and rheumatologic conditions. Those are usually subacute or chronic, typically worse in the morning, and the patient can usually still bear some weight. Oh, and quick tip, if the pain gets worse strictly in the evening or at night, your brain should immediately start ruling out neoplastic causes. And this is exactly why arthrocentesis is your best friend. When you're looking at synovial fluid, laser focus on that PMN percentage. Normal or non-inflammatory joints, like what you see in osteoarthritis, will sit at 25% or less. Inflammatory fluid bumps up over that 50% mark. But if you're staring at a PMN percentage over 80 to 90% plus a massively elevated white count, we're talking over 50,000, that confirms a septic joint. You also need to send that fluid for gram stain and culture, and obviously check for crystals to rule out gouts, negatively birindrant needles, or pseudogouts, positively birindrant rhomboids. Moving right along to section 2, osteoarthritis and rheumatoid arthritis. Let's contrast the two absolute highest yield chronic joint conditions you're going to see. Visually, these two are like night and day on radiography. You really want to cement this image in your mind. Take a look at the left. Osteoarthritis gives you these hook-like osteophytes, subchondral sclerosis, and asymmetric joint space narrowing. Now shift over to the rheumatoid arthritis hand on the right. RA doesn't just narrow the joint space, it literally destroys it with these classic periarticular erosions. On test day, the clinical story is just as stark. If you've got an older patient, say over 40, with brief morning stiffness, like less than 30 minutes, and hard bony crepitus, that points straight to OA. For OA management, think stepwise. Start with exercise and weight loss, move to topical or oral NSAIDs, maybe throw in duloxetine or capsaicin before you even consider surgery or chronic pain management. On the flip side, prolonged morning stiffness, that points straight to RA, which, by the way, carries a huge risk for osteoporosis. Just as a quick aside, if that chronic inflammatory pain is in the back, gets better with exercise but worst at rest or at night, pivot to ankylosing spondylitis. And if the arthritis pops up after a chlamydia infection or enteritis, think reactive arthritis. All right, let's pause and test this logic real quick. What's the next best step for a patient with rheumatoid arthritis who has had persistent symptoms for over 6 months, even while on methotrexate? Well, the answer is either to step up by adding a biologic agent like a TNF inhibitor, or you go with parallel therapy and add a non-biologic agent like sulfasalazine or hydroxychloroquine. Keep in mind, methotrexate is your core initial therapy for RA. You always want to mitigate its side effects with folate and make sure you screen for hepatitis B and C before starting it. If you decide on hydroxychloroquine, you've got to monitor their eyes. And this is absolutely crucial. Before any RA patient gets intubated for surgery, you have to evaluate them for cervical myelopathy so you don't accidentally cause a spinal cord injury. Before we move on from RA, you absolutely must lock in this triad: severe erosive rheumatoid arthritis, splenomegaly, and an absolute neutrophil count under 2,000. That equals Felty syndrome. Here's a massive board clue for you. Never, ever diagnose Felty syndrome in a patient with severe RA unless you explicitly see neutropenia on their lab results. It is an absolute requirement. Okay, on to section 3, the acute hot joint. We are shifting gears to those must-not-miss acute diagnoses that need your immediate attention. Let's do another pause question to get you thinking about the diagnostic funnel here. A patient with risk factors, say older age, diabetes, IV drug use, alcoholism, or maybe recent intra-articular steroid injections, comes in with a 3-day history of fever, unilateral knee erythema, severe pain, and swelling. What exactly are you doing next?
The answer is urgent arthrocentesis. You've got to aspirate that joint before you anchor on something like gout.
Sure, gout causes abrupt monoarthritis, often triggered by diuretics, low-dose aspirin, CKD, or alcohol, but septic arthritis progressively worsens over a few days. The fluid analysis here is both diagnostic and therapeutic, and for septic arthritis, it's going to show a massive leukocytosis. Now, if it does turn out to be a gout flare, your first line is NSAIDs or colchicine. Unless they have renal failure, then you switch to corticosteroids. Oh, and fun fact, losartan and calcium channel blockers actually help lower uric acid. But remember, finding gout crystals does not rule out a simultaneous septic arthritis. Once you actually have that joint fluid, do not sit around waiting for cultures. Treat empirically based immediately on the gram stain. As you can see, hit gram-positive cocci hard with vancomycin. If it's a gram-negative rod, go with a third-generation cephalosporin. And if microscopy is totally negative but you still strongly suspect infection, cover all your bases with vanco plus a cephalosporin. One more thing to watch out for. If you see the classic triad of purulent monoarthritis or tenosynovitis, dermatitis, and migratory polyarthralgias, you really need to suspect disseminated gonococcal infection. Grab synovial stites and NEAT from mucosal sites and treat with ceftriaxone plus chlamydia coverage.
All right, Section 4, Pediatric Joint Pathology. Let's take this exact same algorithmic logic and apply it to kids.
Time for another quick scenario. Imagine a child is brought into the ED. They absolutely cannot bear weight. They have a fever, their white count is north of 12,000, and their ESR is over 40. Looking at the kosher criteria, what is highly likely going on here?
Well, meeting all 4 of those kosher criteria points straight to pediatric septic arthritis. This kid is going to look sick, and they need immediate joint drainage and IV antibiotics. Now, contrast that with a well-appearing child who maybe has a low-grade fever but is actually still able to bear weight. That's likely just transient synovitis, which you manage conservatively with rest and NSAIDs.
But what if the pediatric joint pain is chronic, lasting at least 6 weeks? Then we're talking about juvenile idiopathic arthritis, or JIA. This can show up systemically with daily quotidian fever spikes, an evanescent rash, hepatosplenomegaly, and lymphadenopathy. Or it might be polyarticular or oligoarticular. But please, take this to the bank for JIA. All subtypes require regular ophthalmologic screening. Untreated uveitis in these kids is completely asymptomatic, but it can cause rapid, irreversible vision loss.
Finally, Section 5, a rapid algorithm summary. Let's lock in this diagnostic map with a fast-paced review of those ultimate high-yield associations.
Number 1, an acute, hot joint that cannot bear weight is septic until proven otherwise. Your very next step is always an urgent arthrocentesis. Number 2, mechanical joint pain in an older patient featuring brief morning stiffness and radiographic osteophytes? That always maps to osteoarthritis.
Number 3, systemic inflammation with prolonged morning stiffness and erosive joint destruction on imaging. That is the absolute hallmark of rheumatoid arthritis.
Number 4, severe RA combined with an enlarged spleen and a drastically low neutrophil count firmly secures your diagnosis of Felty syndrome.
And finally, number 5, any child diagnosed with juvenile idiopathic arthritis has to undergo immediate routine screening to catch silent, vision-threatening uveitis. When you're staring down a complex, confusing joint pain scenario on test day, trust the strict branching logic we've covered today. Don't let the distractors blur your vision. So the next time you see a hot, swollen joint, ask yourself, what is the very first branching point I need to establish?